Good evening. My name is Gautam Siram. I'm going to be talking about joint replacements in the setting of COVID. I would like to thank the Gildenhorn Institute for putting these series of talks together. At the end of the talk, I will take any questions. If you could type your questions in the Q&A portion, and I will try to get to them one by one. And so I'm going to try to limit this talk so I can answer most of your questions. But so this is COVID now, as you know, has become our new normal. Just a little bit about myself. I'm at Summit Orthopedics in Chevy Chase, Maryland. I'm an assistant professor of orthopedics at GW. And the director of the outpatient program at Sibley, and I'm also a board member at the Anderson Orthopedic Adult Reconstruction Fellowship Program. So a little bit about my interests. So I do close to about 500 joint replacements a year, both primary and redo surgeries. I get referred a lot of complex redo surgeries that I do almost on a weekly basis. I also am trained in both computer navigation and robotics. I am an anterior approach surgeon for hip replacements. I also do revisions through the anterior approach, and I teach other surgeons nationally for anterior approach and also revision anterior approach. I also do minimally invasive total knee replacements, again, computer navigation, robotics, custom implants, and then partial knee replacements, which I'm a big fan and big advocate of. So this talk is more to address the situation of COVID and how to proceed during this time. What is clear now is that the issue of COVID-19 is not something that's going away anytime soon. We will likely continue with some type of either face mask or restricted kind of with social distancing, testing, and all that well into 2021 and perhaps even into 2022. So the question is it safe to undergo surgery while this is all going on? What is being done to ensure that it is safe? And then the big question is, should you wait? Should you wait until things kind of quiet down and then proceed with surgery? So to address the first part, is it safe? So we've restarted our elective surgeries really towards the middle to latter half of May, and in June really started to pick up in the hospitals. And what we've noted in our kind of short interval is there's have been no increase in complications in and around the time of surgery, whether that be periprosthetic infections, so infections around the joint, no increased respiratory complications, and perhaps the most important, no known COVID exposures as a result of patients coming to have surgery in an elective fashion. So what is being done to kind of maintain this safe environment? So first and foremost is testing, right? So anyone who comes to the hospital for an elective surgery must get tested about 3 days prior to surgery. And then when they get tested, the recommendation is that to the extent that you can is essentially quarantine or kind of lay low for right up until your surgery so that you can minimize any further risk in that 3-day interval. All staff is routinely screened, so we do temperatures, any exposure risk. Everybody in the hospital wears masks, so that's not an option, that is mandatory. And then in terms of volume or traffic in the hospital, so we are limiting the number of family members, friends, et cetera, that can come visit the patients. Prior to this week, actually, no family members or no friends could come visit patients we are starting to ease up some of the rules, and that's going to be kind of brought out over the next week or so. But essentially, it boils down to each patient will have one, what we call care partner, where they can come into the hospital to see their particular family member, friend, the patient. And all those patients will be, all those kind of care partners will be screened on a daily basis. So each day they come, they will undergo a screening process, a questionnaire, temperature check, and certainly have to wear masks. Again, all members of the hospital staff, surgical team, anesthesia, everybody in the hospital has to wear a mask at all times. So it is not an option. The other thing you'll see on a frequent basis is everybody cleaning, washing their hands multiple times a day. Each time you go in and out of a room, patient's room, each time you have any interaction with the patient. And then cleaning, all the rooms, operating rooms, beds, surfaces, equipment, they are undergoing more intensive cleaning and also frequent cleaning process. So there has been a separation in the number of surgeries you can do per day so that we can, one, be mindful of our personal protective equipment supply, and also do a terminal clean down between each surgery. Other thing that's very important is there is a complete separation of COVID positive patients in the hospital, so that all elective surgeries, all patients coming into the hospital for non-COVID related matters are nowhere near anywhere patients who are COVID positive. And as of yesterday, there has been only one patient who is in the hospital for COVID. So the census for COVID positive patients, all in all, at Sibley have been fairly low, even at the peak of this in May. So that the area in general has done a very good job of taking this seriously, of social distancing, and so all in all, the numbers have not been as high as was once predicted for this area. But it is something that we have to be very mindful of, that we have to continue to make sure we maintain these low levels. Again, we are doing limited volume, so we're not doing the same number of surgeries that we have. And again, that is for more time for terminal cleaning between cases, decreased exposure. If there's decreased traffic, then there's decreased exposure. We're also limiting the number of people that can come in and out of the operating room, and also even the physical therapy gym. There is social distancing being maintained in there as well. So all throughout the hospital experience, which generally is not more than one night for most elective surgeries, in particular most elective joint replacements, we are maintaining the social distancing, we are maintaining the mask wearing, and we are doing everything we can to try to maintain a very safe environment. So the other part of this process is outpatient surgery. So outpatient joint replacements is nothing new. It has actually been around for the last 8 years. It has picked up steam in the last 5 years. And in the last, I would say, year and a half to 2 years, it has been slowly adopted by Medicare. So Medicare is now allowing outpatient total knees replacements done. And starting in January, they're going to start allowing outpatient total hips. They will allow outpatient total hips in the hospital. But if you are in a surgery center, that is going to be January 2021. So this has been a progression, and this is going to continue to be the case. And there is no doubt that within the next few years, that joint replacements will only be classified as an outpatient surgery, and staying one night will not even be an option. So that Medicare is really going to kind of push the ball on this, and commercial carriers are going to be following suit. And so that is the new norm. COVID has just expedited this process a little bit, but we were going in that direction to begin with. And if you look at our data for outpatient surgery, we have pretty robust data on it, and the data shows that it is as safe as inpatient stays, that there are across the board higher patient satisfaction scores, and there's no difference in complication or readmission rate. So that's the critical aspect of this, where it is the same product, perhaps even better because the satisfaction scores are higher, without any increased risk or complication. So this is where things are going. Again, COVID-19 has really pushed it in that direction, I think for the better, because the less time you're in a medical environment, hospital setting, high traffic area, obviously the less risk of exposure. So that is something that we are heavily pushing. And then this is kind of my last slide here, which is should we wait? And this is a common question I get probably on a weekly basis, seeing patients who have very arthritic joints and who are in a significant amount of discomfort or pain, and yet who are apprehensive given the situation about whether to proceed with surgery at this time. So current models suggest that we will be dealing with this well into the end of 2021 and likely beyond. If you look at the 1918 flu pandemic, it was about 3 to 4 years before there was a return to a normal life. Just this morning, I heard or actually read an article that is not, 2024 is the predicted time period where things will be back to completely normal. So that's a long time. And this is even despite a potential vaccine coming into play, because as we all know, vaccines are not 100% effective. They tend to be, if you look at the flu, for example, it could be anywhere from 20 to 50% effective. So a vaccine is part of the process, but certainly not the magic bullet to this. So this is essentially going to be a new norm for an extended period of time. And so the question that patients have to weigh is, one, can they wait that long with the painful joint? Can they maintain a certain kind of quality of life that they want to? And then the safety of that. So, you know, as your joints become arthritic, there is safety issues in terms of ability to ambulate, ability to use stairs, ability to do basic everyday things without having a fall. So that's something that you have to weigh in the risk-benefit ratio of this. Again, back to our early data that show that there has not been an increased risk of complications with the way that we are doing it, with the aggressive testing, aggressive social distancing, aggressive mask wearing, and taking this disease seriously. And then again, back to the health complications from waiting. As we all know, as we become less ambulatory, there are other issues, problems that stem from that. That is decreased cardiac health, weight gain, and other issues that stem from those issues. So I think there's certainly there are pros and cons with each way. But given that this is not going to be a short-term issue, what we have been doing as a medical community is trying to make sure that we can continue to serve our patients in a safe fashion and get results that are that with no increased risk of complication. So with that, this is our contact info. I would say the best way to either come see me or ask questions is to email at hiptome@gmail.com. You can also call the office at 301-657-9876 for an appointment. And with that, I will start going through some of these questions. So let me see here. All right. So the first question is, do these safety precautions only apply to Sibley or also to Suburban Hospital? They do apply to, I believe that they're taking these precautions at most hospitals. Sibley and Suburban are both Johns Hopkins hospitals. So I would assume that they are making the same precautions as they, as at Sibley. So the next question is, what are my thoughts about going to rehab and what precautions can be done to make it safe for this particular patient to go home? So my thoughts on rehab in general, even in the absence of COVID-19, is that it is not a place to go. I'll be completely honest. In general, the patients who end up in inpatient rehab facilities are our sickest patients. So there is increased risk of exposure at rehab facilities. So I really think, if at all possible, it is the best case scenario is to avoid going to a rehab facility. Now, there are certain instances in complicated revisions or redos, or in certain situations where it is not safe to go home. However, in a primary joint replacement, that means that's the first go-around hip replacement. In the absence of a major complication, the insurance companies will not even approve it. So that's those are kind of my thoughts of rehab. In terms of what can be done to make it safe for patients to go home in that scenario, well, I think having a good kind of social network to check on the patient, to help. You can set up in-home physical therapy, depending on the situation and scenario, and that is a possibility. And then making sure that the home environment is safe, so avoiding any obstacles that could potentially cause falls, making sure things are accessible. But again, I think the biggest thing is having someone nearby able to check on the patient or help out for a limited amount of time. Next question I got is would you recommend a total joint replacement during COVID-19? And my answer is, if the symptoms gotten severe enough to the point where daily life has been affected, where the pain is so severe, and where there is potential risks of not doing the surgery, then yes, I feel that it is very safe given all the precautions that have been taken. Safety of physical therapy. Next question is safety of physical therapy. So I guess, most outpatient physical therapy facilities, including Sibley, again, are following carefully the social distancing guidelines, mask wearing guidelines, hand washing guidelines. And I think that's really as safe as we can be. Certainly, if patients and or providers have symptoms, it is their duty and responsibility to do the right thing and either not show up and avoid any exposure. So this goes both ways on both the providers and the patient's role. But again, I think with the mask wearing and hand washing and the distancing, it is really as safe as we can get. Minus not having a vaccine and also not being free. Okay, my son, I got a little one here. Okay, I'll be there in 1 second. Okay. Okay. So what is changing with physical therapy after total knee replacement, first at home and then as outpatient? So what I always recommend is going straight to outpatient. Okay, I always recommend going straight to outpatient because I find that in-home therapy is not aggressive enough. And so what's critical in the first 6 weeks. Okay, all right. If I can't fix this, I certainly can't fix a joint. So let me get this. Yeah, here, why don't you go here? I gotta hold it right here. So I always recommend going straight to outpatient. Because your range of motion of what you get in the first 6 weeks is what you're going to get. So it is critical to be as aggressive as possible in those first 6 weeks. So it means that going to physical therapy, I recommend 3 times a week. In-home physical therapy is just not aggressive enough. So I'm a big advocate of that. I really push that and try to avoid the in-home physical therapy. So next question, what is the difference between a regular knee replacement and minimally invasive? So the big difference is how you access the knee and how you access how you avoid the extensor mechanism. So one of the things I do differently is I try to avoid the muscular extensor mechanism as much as possible. That allows patients to move the knee quicker, to do what we call straight leg raises, and to activate that muscle as quick as possible. So that's the way I was trained. It's the way I pretty much do all my knee replacements, and I'm personally a big advocate of that. Is obesity a barrier to knee replacement? It depends. So it is not as though you cannot have a knee replacement in the setting of morbid obesity. However, it does increase certain risks. So it does increase the risk of infection. It does increase the risk of component loosening over time. I do the knee replacement slightly differently to decrease that risk of loosening over time. There are certain scenarios where it is the right thing for me to say, look, it's better we do undergo a period of weight loss before undergoing the surgery. And if there are situations where I feel that is the right way, then that's what I do. Next question is, if pain has been managed so far with cortisone injections, at what point would you suggest I move to a total replacement? So it is when the cortisone injections and other non-invasive modalities stop working. So you will know what will happen is the cortisone injection, which has been working well for some time, will now only work for a limited period of time. And I only do cortisone injections minimum 3 months apart. So if the injection is lasting less than 3 months, then I recommend thinking about surgery at that time. But if it's working well, then it's something you can continue for really an indefinite period of time. If as long as you're doing it spaced out greater than 3 months apart, the risk of any complications, issues from the cortisone itself, because it's such a small amount, is very, very, very small. It's only if you do it more aggressively than that, which I do not do. I think the last question is, if you need an anterior hip replacement but needed 2 large screws put in, how long should it take to recover? So I guess I don't understand the large screws. Do you have screws in there that are currently in, and those have to be removed before putting the hip replacement, or normally, traditionally, we don't put screws in. We put screws in the socket sometimes if we want a little extra fixation, but there are no screws put in on the femur side. So if you have hardware in place and you have to take that out to have a hip replacement, the recovery time is totally dependent on where the screws are, how much bone loss there is. So it is very variable from patient to patient. But certainly it can be done through the anterior approach. And again, I do all my revisions through the anterior approach. Let's see here. There are a few more questions. What are the main reasons for failures of hip replacements? If you look at, so there are certain risks that are more common, but overall low, right? So the risk of infection is about 1.2%. The risk of what we call dislocation, meaning the hip popping out of place, is about 0.6% to 1%. Anterior approach has a lower risk of dislocation. And then risk of what we call loosening, aseptic loosening. That's less than 1%, where in some scenarios, if we do what's called a cementless implant, the bone doesn't grow into the implant for whatever reason. Again, that's less than 1%. Those are probably the more common reasons for failure. And again, when I say common, they are definitely less or they're approximately 1% or less. The last one I would say is when putting in these hip replacements, sometimes you can encounter a fracture that occurs when you're putting the implants in, because we have to put them in very snug into the bone. That's something we can treat, but it may prolong the recovery period for a little period of time. And I think, oh, sorry. So one question I had was, okay, so there were screws put in, and now that has failed, and so you have to do a hip replacement. So, hopefully this experience with the hip replacement will be much easier than the screws, because in general, if there's significant osteopenia or the bone is very thin, we can cement the components into place, which will allow the patients to bear weight on it right away. So hopefully the recovery period will not be significantly longer than just a standard hip replacement. But again, without seeing the x-rays in detail and seeing what else is going on, I can't give you 100% answer, but it should be a significantly easier rehab than the screw placement. And the next question is, if screws are needed for one hip, what is the likelihood you need screws in the second hip? I would say it's 50%. Just because you need it on one hip doesn't necessarily mean it'll happen to the other side. So it all depends on the tactile feedback we get when we put these implants into the bone, and we can get a good sense of if it needs any additive fixation. And I think that's it.